like to do is start with a general review of anatomy. The trickiest thing to talking about to a big audience like this is, gosh, everybody knows a little bit, some people know a whole lot. But I like when we start at the beginning. And I don't want you to think that this talk is geared, that I'm talking down, because I know we have all sorts of experts in the audience, but how about we just start from the beginning? So I like to think of the heart as a home. I like to think of it as a house. The heart is fun to talk about because it's a structure. So I think of it as a place, as a house, as I said, it has an upstairs. There are two rooms. There's a right atrium, we call it, and a left atrium. The right room and the left upstairs room. There's a dividing wall. It's called the atrial septum. Remember how Dr. Walters yesterday said she's a fast talker? I am too. I have to kind of slow myself down. All right? Downstairs, we have two rooms. The word is different. The right ventricle, the left ventricle. The dividing wall, though, is the name is the same, the ventricular septum. And then in between the upstairs and the downstairs, I call them swinging doors. The old-fashioned swinging doors, back and forth. And these are called the valves, the tricuspid valve and the mitral valve. And this is my little diagram. This is called our home. This is the Casa Bonita. And this is the right atrium. Mrs. Lopez, I'm not sure whether you're seeing them today, if they're here. But this is the right atrium and the left atrium. Right ventricle, left ventricle. Tricuspid valve, mitral valve. Going into the right atrium is a structure called the superior vena cava and the inferior vena cava. And these horribly long words are just Latin words. And then going into the left atrium are the pulmonary veins. Leaving these big ventricles, this is the pulmonary arteries and the aorta. But there's an even better way of looking at the normal heart. I'm going to advance it this way. Now, this is a nice link to a diagram that Gina Baffin here has prepared for Nemers. And what we're going to see is if we can make this link work. Folks, if anybody wants to write this down quickly, it's nemerscardiaccenters.com. Now, what's so nice about this is what we have is basically the diagram that I've shown you. But Gina has cleverly animated this using little blue drops to signify unoxygenated blood cells. The red ones have gone to the lungs and have picked up oxygen. Right, next time it comes around, I'm going to help you follow it. This is blood coming from the body. This all comes back here. No oxygen. Right atrium, right ventricle, pulmonary artery, out to the lungs, picks up oxygen, comes back, left ventricle, aorta, out to the body. Let's do it again. Back from the body, no oxygen, right ventricle, pulmonary artery, out to the lungs, oxygen, left atrium, left ventricle, aorta, head and neck, body, back again. I'm not going to talk, you just watch it for a while. Students at like 11 o'clock at night. It's great. So on your own time, you can go back and do this. So now that you have the image, I'm going to go back and show you some text. So these pipes, I've shown you the room. The pipes now, the drainage, enter the house from the body. The superior vena cava, inferior vena cava, from the lungs, where remember they were red, we got oxygen, the pulmonary veins. So these veins here have blue blood, no oxygen. So these veins here have the red blood. Pipes leave the heart, these are the great big ones, going to the lungs, the pulmonary artery, and to the body, the aorta. Now, again, this house analogy, there's internal plumbing, coronary arteries, electrical system, the conduction system. So now, let's kind of switch gears. That was the normal. Let's talk about the abnormal heart. And there are some different patterns. And folks, by the way, the handout that's in your folder, it corresponds exactly to what I'm showing you, with some slight modification. But, these are really the same thing, so you shouldn't have to take too many notes. I'm going to tell you about 3 different patterns of heart abnormalities. I'm going to tell you first about what we call congenital heart defects, or sometimes you see people writing on the chart CHD. Sometimes people use the expression cardiovascular malformation, CVM. It means that something is wrong with the structure, the physical thing, the way the heart has been put together. It means that there's an error early in development in the first 8 to 12 weeks. So I'm telling you that not because that's some little bit of esoteric science, but it means that for somebody who has a child with a heart defect, suppose that somebody has nothing to do with Costello syndrome, we might meet a person who's had a child with a heart defect. And the mother might say, oh, I'm so embarrassed, I have to tell you this, but I got wicked drunk, when I was like 4 months, and I just, like a whole weekend of drinking. It doesn't matter. It has nothing to do with the heart defect, because heart defects happen really early on, 8 to 12 weeks. So whatever happened to the heart happened early on. Heart defects are traditionally present at birth, but guess what? Not always. Because we know that prenatal ultrasound can detect them in the fetus. And we also know that some heart defects are so sneaky, they don't get detected until somebody's an adult. And now I'm going to tell you about the types of heart defects, because if you were to look it up on the internet or in a book, the list is technically really long. I mean, it's overwhelming. It looks like a list of like 50 or 60 or 70 defects, but you can put them into categories. So remember the different types of, or the different anatomy of the heart. So the first type of a heart defect is a hole in the dividing wall. And we call it a septal defect. If it's a hole in the top of the heart, we call it an atrial septal defect, ASD. In the bottom, we call it a ventricular septal defect. You know what, I'm going to pause and just ask you a question I should have asked at the beginning. How many of you have children who have a heart defect? About a third. Okay, well, that's going to be meaningful when I get to the end of the talk. And let me further clarify. How many of you have a child not with a heart problem, but with a heart defect, a CHD? A little bit fewer than okay. Now to continue, another type of a heart defect is a plumbing problem with those pipes, those blood vessels we were talking about. One is called coarctation, which is a narrowing of the descending aorta. The others I'm going to go through quickly. Transposition of the great arteries, something called tetralogy, truncus, and many, many more. Too many to even talk about for this particular lecture. Another type of a heart defect has to do with those valves. Those valves can be leaky. And a fancy word for leakiness is called regurgitation. Not regurgitation like the kind of regurgitation we think of from the esophagus. But it's a kind of leakiness, something similar. Tricuspid regurgitation, where the synonym is insufficiency. Mitral regurgitation, insufficiency. Aortic regurgitation, pulmonary regurgitation. The opposite of being leaky is tight, or so tight that something's even absent. And the valves are tricuspid stenosis, tricuspid atresia, pulmonary stenosis, she said in a loud voice, pulmonary atresia, mitral stenosis, aortic stenosis, and super duper aortic stenosis atresia, something called hypoplastic left heart syndrome. And how about a show of hands for this defect that I put in bold? Because you're going to see this is kind of characteristic for Costello syndrome. And so now we've got a nice link to this wonderful website. I enjoyed it so much, Gina. When I teach in my birth defect lecture, I show this site all the time. I love it. So look what this is showing. First of all, notice the emphasis on the blue red cells. So this is the right side of the heart that it's focusing on. And it's showing you blood coming in from the right side, going into the right ventricle. Do you notice how the right ventricle is looking a little small Can you see how the muscle here is a little bit thick? They're trying to show you that the heart is pumping a little bit harder. And notice how this little valve here is made, she said, the narrow pulmonary valve. A little bit thinner, it's working a little bit harder. Pulmonary stenosis, and there's text over here. I'm not even going to read it. If you guys can see it, I'll let you read it yourself. Now you need to know that pulmonary stenosis is not the same in every child, okay? In some children, the valve is exactly, it looks really the same as in an unaffected child, but it's a little bit tighter. In other children, this pulmonary artery is really tight. And in other children, this right ventricle is extremely small. So it's a spectrum from mild, imperceptibly narrow, to something that's extremely small, something we call critical pulmonary stenosis. So please accept that there's a spectrum. In your child's heart, for those of you who have this condition, may not be exactly the same. But this gives you a pretty good image, huh? Now we're going to switch gears and go from pulmonary stenosis to this other entity, this other heart problem called cardiomyopathy. And the root here, myopathy refers to muscle. And in fact, cardiomyopathy refers to abnormal heart muscle. So forget the idea of heart structure, because now we're talking about heart muscle. And it means that the house of the heart as a house is assembled correctly, but not the walls. Okay? The bottom part, that wall, the pump. It's hypertrophic, it's thick. And now this is what can be confusing. And for those of you who've had children with cardiomyopathy, you've heard some of these terms. It can be symmetric, thick on both sides, or the opposite, asymmetric, thick on one side more so than the other. It can be concentric, thick all the way around, perfectly all the way around. It can be obstructive, producing a gradient, or non-obstructive, which means it can look bad, but actually there's not too much obstruction going on. The opposite of hypertrophic is dilated. And we've always X'd this out from Costello syndrome, but I put it on the slide just so you can just see it. Switch gears again. The third heart problem that we're talking about are rhythm abnormalities. This is a little bit tricky. I'm going to load you up with some terms. You know what? How about I pause for a second? Let me go back to this slide. And before we even go on, any quick questions here?
I was a little confused with structural versus cardiomyopathy. It sounded like they're the same. And in terms of something not being built up.
They're really not, Lisa, because the idea of a structural heart defect means that the way the chambers are lined up and the drain pipes and the arteries, the way things are hooked up, is incorrect. In cardiomyopathy, there's an implication that those things are hooked up. However, maybe this is what you're thinking of. You can have the two together. You could, for example, certainly have a cardiomyopathy and an ASD, which is actually a common situation. And you could also have a cardiomyopathy and the appearance of what's called subaortic stenosis. But the thought is that in the latter situation where you have cardiomyopathy and subaortic obstruction, the obstruction below the aortic valve is based on this muscular hypertrophy. Does that make sense?
Just try first.
Did I?
Yeah.
Okay. So it can sound like you've got two things going on, but what I'm trying to characterize is in the second example, you really have one thing going on, creating the appearance really of two things. In fact, in Costello syndrome, that I'm going to get to, you have all three things. Which brings us to the third entity, which is a rhythm abnormality. Now, we talked about, there are many different ways to describe rhythm abnormalities, so what I'm going to give you is just one example. I'm going to divide rhythm abnormalities, for starters, by chambers, top and bottom. The top chambers in the heart are called those atria. And I'm going to subdivide them into fast rhythms, which are called tachycardia. In a lot of heads would shake. How many? Yeah, we know, huh? Fast and regular tachycardias. They can occur in the same place, many different places. They can be fast and irregular. And I'm going to ask Dr. Bassett to be kind to me because I'm going to do kind of like this, kind of a general approach. There's so many ways to be more precise, but I'm going to try and put them in some general categories. Supraventricular tachycardia, SVT, is such a common term. Usually refers to a kind of fast, regular rhythm, usually being generated from the same place in the heart, like Morse code being generated from one little place, being generated. But sometimes that fast rhythm is being generated from a couple different places in the atrium, the right atrium. And what I've noticed is that cardiologists use different terms depending on their preference, how they want to define or refine the term. I've noticed that adult cardiologists use them slightly differently. But in general, when we're talking about the Costello patients here, we have been fairly generous and will lump these apart from these. So the ones that you may have heard have been chaotic atrial rhythm, multifocal atrial tachycardia, ectopic atrial tachycardia, and junctional. And in my review of the Costello patients, all of these have been used, and we feel that they're all similar enough to put them together. Fast and irregular. So instead of being it might be a little irregular. It's usually thought of as fibrillation or something called flutter. They're actually different, but what's similar about them is that they're irregular. And finally, there's something called premature atrial beats. People spend years going over this. I'm trying to do this in just 5 minutes. Now, another place that you can have a rhythm problem is in the lower part of the heart, the ventricles. It can be fast, see that word tachycardia, can be irregular fibrillation, can be premature and irregular, and just premature ventricular beats. I'm going to go into this too much because this could be an entire talk about whether these can be independent or secondary to cardiomyopathy. We can also have a problem not just with the chambers, but with the entire conduction system, start to bottom, from the atria to what are called the nose down to the bottom. Now, along the way, you can have something called heart block, which is just what it sounds like, blocking of the heart conduction system. In a paper that I wrote with many different collaborators who provided me many patients, and we gathered up from the literature a fairly large number, it looked at about almost 100 patients, which was a good number. It was published last year, and since publication, in the literature I found at least 18. It seems to grow like every month, 1 or 2 dribble in. When I made up this slide, I knew for sure that I had at least another 5 patients who had a heart problem, and possibly in all likelihood, there are probably a couple more. My very best guess is that there might be at least 150 patients with Costello syndrome. At the end of this meeting, when some of us get together, we're going to try to kind of do a count up, do a census, I guess. And in my count, I have not found a sex predisposition for Costello syndrome. It's about equal. And as you all know, we have a fairly wide age spread. We certainly have younger patients as well as older patients. This is the number these are the numbers I would like folks to try to remember. Any heart abnormality at all, occurs in about 60%, so less than 2/3. And these are the numbers I would like you to try to remember. And I've rounded them off. I'm a big believer in round numbers. This is not the place for 0.0156 or something. A structural heart defect, CHD, occurs in about 1/3. Cardiomyopathy hypertrophic in about 1/3. And a rhythm abnormality in about 1/3. What I don't want people to do is add these together because there's a lot of overlap. But if you were ever giving a talk or making up a slide, this would be the number to remember, for example, this kind of division. So any heart abnormality in a little bit less than 2/3, and then 1/3, 1/3, and 1/3. A combination of these occurred about 25%, 1 out of 4. So about 1 out of 4 had some kind of combination. So it's common to have this and this, or this and this. I'm going to show you how they combine later on. But it gets a little bit complicated, so I'm trying to keep it really simple. Just try to remember some of this breakdown. Just for the fun of it. How many in the room have a child with any heart abnormality? Let's see if it approaches about 2/3. It's about that. I mean, just doing this kind of visually. I mean, it's kind of close. And let's try, how about a structural heart defect, a CHD? I don't know if it's about 1/3. Okay, thank you. And let's say cardiomyopathy. You know, maybe about that. And how about a rhythm abnormality? I mean, close to it. You know? I mean, it's certainly not like it's swaying in one direction. I mean, it's close. And so to go over this a little bit more again, a congenital heart defect was found in 30%, a little bit less than 1/3, and the most common one was pulmonary stenosis. For the sake of this discussion, we're not going to fine-tune every single thing, but I'm just going to give you some general things. So then I want to talk to everybody in the audience. I want to tell Dr. Backer too. Well, what's so interesting was what we don't see. You really don't see some of these major complex heart defects. You don't see coronal truncal, what are called AV canal, single ventricle heterotaxy. And for me, what this says to me is that this is not so much an early developmental. The impact of the gene that we think is present in Costello syndrome is not so much an early developmental impact. I think that the pulmonary stenosis is telling us this is more like a dysplasia than a really early developmental gene. Is the pattern that we've seen, this pulmonary stenosis, unique? Not at all. What other abnormalities do we see? No surprise, we see things like microvalve prolapse, regurgitation, and what we call thick valve tips. And to the families and to the parents, this may not really make sense, but to those of us who know some of these conditions, this is a pattern. This is something that we see in some of the other conditions. And what are these other conditions? And I know the group is familiar with these. Noonan syndrome, CFC, two others you may not have heard of, something called Alagille syndrome and something called neurofibromatosis. Pulmonary stenosis, these thick valvular tips, these are things that kind of cluster together. They travel together. Number two, let's talk about cardiomyopathy. How common? A little bit less than 1/3. I was using round numbers before, 30%. And the pattern, first of all, I have to tell you folks that the pattern of the cardiomyopathy in the literature, or even among the patient data, wasn't always crystal clear. This is not really precise science like we can sometimes get in a laboratory. But from what I could distill, I could tell you that in at least half of the cases it is left-sided. It is both-sided in 10%, and that's very important because it's not a clear HCM, ASH pattern. Sometimes it seems more like a metabolic cardiomyopathy, kind of diffused by ventricular, and it was unclear in fully 40%. Now, what about treatment? It was not well studied in my paper because I simply didn't have that data. But clearly the spectrum of monitoring, clearly the spectrum of drug treatment was vast. A whole variety of drugs, and from being here I picked up some things from Colin, from Wayne, who mentioned to me some of the drug treatment that their children receive. I don't think I'll mention from the podium, maybe later on we can have a discussion with Dr. Baca so that you can communicate to them, to her yourself, what you experienced. Because I think that it's really important that for patients who have had good experience with drugs, bug your doctors. Because it's great when you tell me, and I love hearing it, but I really can't do anything with it, if you know what I mean.